Well, I'd like to thank Dr. Miller and Dr. Lublin for inviting me here today. This is a pleasure and an honor for me. I get to do one of my favorite things in the world, which is to talk to people about multiple sclerosis and exercise and physical therapy. And what I'm hoping to do today is change the way that some of you think about what physical therapy and exercise can do for you, particularly for people with multiple sclerosis. I want to make the case that multiple sclerosis is a special case, that as Dr. Miller said very clearly a few minutes ago, all therapy is not equal, and multiple sclerosis requires very specialized physical therapy. So over the next half hour or so, I want to give you a few specific examples from my research and the research of others, and then I'm going to try to have what Dr. Miller has requested me to have the largest group exercise program in history. We'll see how that goes. If I can figure this thing out here. Dr. Miller, Dr. Lublin, Dr. Krieger, they are physicians and they look at multiple sclerosis as a disease of demyelination, and that is correct. As a physical therapist, I look at things differently. Multiple sclerosis is a disease of mobility, okay? It's a disease that results in difficulty with walking, with moving, with balance. Okay? So when a MS patient comes to see me, that is what I focus on. I, of course, look at all the information the physician hopefully sends along, but what I'm interested in is how specifically has the multiple sclerosis affected their ability to move? Because the treatment program that I put together has to very specifically address those movement issues. Okay? Now, I think I don't need to tell anybody in this audience that persons with MS should make exercise part of their lifestyle. I think that's not new information anymore. I think we all can agree that it's going to result in better management of the disease, it's going to result in better management of mobility deficits, it's going to result in better quality of life. However, exercise is different for persons with MS than for persons without MS. There's different rules for exercise for persons with MS than for those without. And therefore, if you're going to be looking for either a therapist or a personal trainer or somebody to help you with an exercise program to help you with your MS, make sure they know MS. When you went to look for a physician to help you with your MS, you didn't look for a dermatologist, you didn't look for a kidney specialist, you went to a neurologist, and you didn't just look for any neurologist, you looked for a neurologist who had specific training in multiple sclerosis. And I'm urging you today to try to find a therapist or trainer or somebody who truly understands the disease, because MS is a special case. Okay? MS is a disease of tremendous variability. As a physical therapist, it's one of the things that I'm constantly struck with. I've had the privilege of working with people with MS for over 25 years now, and I can honestly say I've never really seen two very similar cases. Unlike other neurologic conditions that physical therapists commonly see, such as stroke or spinal cord or Parkinson's disease, there's no stereotypical presentation. There's a tremendous variability, a wide array of various mobility deficits, and it's going to depend on the location of the lesion, the size of the lesion, the intensity of the lesion, how many lesions there are. So the hallmark, the stereotype of MS is that there's no stereotype, at least as regards my experience in physical therapy. MS is going to affect your function, therefore, in different ways. Each person has their own specific type of MS, and therefore, you need a customized exercise program. Earlier today, we heard Dr. Krieger talk about how when a physician sees somebody with MS, he or she is going to try to divine what is going to be the optimal medical program for their MS. It's not going to be the same for each person. Depending on how their MS presents, their medical program is going to be a reflection of that individuality. In physical therapy, it's going to be the same. You need a customized program, and it has to meet the specific needs of your specific type of MS. And I want to therefore give you the idea that exercise is a treatment for specific symptoms of MS. I like to tell my patients, I'd like you to think of exercise as a type of medication. If you do your specific exercises, certain symptoms are going to respond. If you don't do your exercises, or similarly, if you don't take your medication, don't expect there to be improvements. Exercise, medication, they all have to be part of your attack on your multiple sclerosis. So if there's this problem, as I said, that there's no stereotypical presentation, how do we put together a treatment program? Well, there are a few things that I see in persons with MS that seems to affect pretty much everybody. And for me, in terms of how it affects exercise, that's the issue of fatigue. Fatigue is, I think we all can agree here, probably one of the most common and disabling of all MS symptoms. My time here won't allow me to go into a big discussion about fatigue, excuse me, but we know that it's multifactorial, and the way it affects physical therapy in my work the most is it significantly limits the ability to engage in an aggressive exercise program. I want people to exercise. I know exercise is going to have a positive effect on their multiple sclerosis if they get the right exercise and perform it correctly, but fatigue stands in the way. We can divide fatigue very roughly into both primary and secondary fatigue. Primary fatigue is due to the primary aspects of the disease. It's a neurologic event. It's primarily due to demyelination, although there are many other factors involved. Secondary fatigue is what I'm more interested in as a physical therapist. And I'll define secondary fatigue this way. As someone becomes progressively less and less active as a result of primary fatigue or other symptoms, the person assumes a progressively less and less active lifestyle. And a type of vicious circle starts. The person has primary fatigue, so they become less active. As a result of being less active, they become less fit. As a result of being less fit, they become less active. As a result of being less active, less fit. And this is a progressive circle, a spiraling downward that I've unfortunately seen over and over and over again. The person is aware that it's happening, but they're not quite sure how to change. They try to exercise, but the exercise doesn't seem to make much of a difference in this. And it's, I think, the role of any physical therapist or trainer or any specialist who works with MS and exercise to try to intervene in this specific area. Okay, so fatigue is obviously a major issue in multiple sclerosis, limiting exercise, limiting the ability to improve with exercise. What else is there? Well, as most of you know, heat is a major issue. Heat has a tendency to worsen symptoms in multiple sclerosis. I think we all know that. Okay. The heat, of course, can be external, and most of you tried making it through last summer where we had all these consistent days of over 100-degree temperature, realize that. However, the heat increase can be internal as well. And certainly, most of you will know that if you have a fever from an infection, it's going to make your symptoms worse. Well, what happens to core temperature once somebody exercises? It increases. So we have another problem here, don't we? If you need exercise to get better, yet exercise raises your core temperature, raises your heat, and increases your symptoms. So again, we have this other fundamental roadblock in how to improve exercise in multiple sclerosis and how to improve the amount and the quality of the exercise. So let's do a quick recap here. What makes exercise difficult in MS? Well, it's the variability. You can't have this one size fits all. You can't have a cookie cutter approach. You have to have specialization. Second, neurogenic fatigue. Okay? Fatigue is far too common in MS to let a typical exercise program, a normal, not well thought out exercise program, be very helpful. And finally, thermosensitivity. Heat gets in the way of exercise. Exercise leads to heat buildup. So we have these three issues. And this is what, unfortunately, I think has led many of my colleagues in physical therapy to, once treating a person with MS, say, well, this person is not a candidate for therapy. That they see somebody with MS, they try a basic program with them, and after 15, 20 minutes, the person with MS can't continue anymore. And tragically, the therapist concludes, this person can't benefit from physical therapy. They can't tolerate therapy. And to me, that's a tragedy, because It shows not that the patient can't tolerate from therapy, but that the therapist hasn't figured out how to optimally treat the patient. Okay. Now, there's a hospital some of you may have heard of on 34th Street called the Rusk Institute. The father of rehab medicine and one of the fathers of rehab medicine named Howard Rusk, in one of his first textbooks on rehabilitation, and I'm quoting from him directly here, he said, persons with MS should not exercise aggressively as it may lead to an exacerbation. And in all fairness, this statement came out many, many years ago. But unfortunately, far too often, patients and the persons who looked after them thought this to be the case, and they pushed patients away from exercising aggressively. They were told to exercise very gently, if at all. And unfortunately, this did a disservice to many persons with MS. And this really changed in 1996 with a study by Jack Petajan out of the University of Utah. And this was a remarkably important study for me and for people who work with MS. It was published in the Annals of Neurology, and I remember a physician I worked with at Burke Rehab named Mindy Azen came running down to my office to show me this. And it was actually a very, very simple study, but what it showed was what was remarkable. Petajan took 54 persons with multiple sclerosis with a fairly wide wide range of disability, and gave them what was thought to be, at the time, a rather aggressive exercise program. 40 minutes a week of aerobic training. It was either upper body cycling or lower body cycling or some combination. Did it for what was considered for a long period of time, 15 weeks. What was found at the end of the 15 weeks? 3 things that were considered at the time quite amazing. First, everybody improved. All the exercise groups improved. They improved in strength and aerobic fitness and body fat and many, many other measures. In the control group, which did not exercise, not surprisingly, no improvements. The improvements seen in the persons with MS were very similar to groups without MS. It suggested that persons with MS will improve in ways very similar to persons without MS if given an exercise program. And finally, and most importantly, and this is what got us all excited on that day, there was no increase in exacerbations as a result of this. Okay? Aggressive exercise program, almost 4 months of it, did not lead to an exacerbation. Okay? Why is this? And again, this was something I believe Dr. Krieger was talking about earlier. You have to differentiate between an exacerbation and what some researchers refer to as a pseudo-exacerbation or a false exacerbation. An exacerbation means specifically an acute demyelinating incident, that there is something hard that is happening in the nervous system. A pseudo-exacerbation means a transient worsening of symptoms, with the emphasis on transient. The person may exercise too hard. Okay? As a result, their system heats up. The thermosensitivity effect takes place, and they feel a worsening of symptoms, a worsening of fatigue, of spasticity, of paresthesias, of perhaps cognitive symptoms. Okay? But this is transient. It goes away, and it's not an exacerbation. And as little as 1 week ago, I saw in my office this beautiful young woman who was recently diagnosed, and she said, "Herb, I don't want to exercise because I'm afraid of getting an exacerbation." And this was someone who, prior to her diagnosis, was an extremely serious exerciser. And she was quite sure that the worsening of symptoms that she felt when she exercised was the same as the worsening of symptoms she felt when she had a true exacerbation. And I had to tell her, show her the research, bring her to all my colleagues who are also MS experts. We all had to assure her, no, this is a pseudo-exacerbation. You're not getting worse. The exercise is what's going to get you better. The not exercising is a bad idea. So that certainly solves the issue of you're not going to have an exacerbation as a result of exercise, but it is going to, again, lead to the question of how should you exercise? And this leads to what I feel is one of the basic conflicts of multiple sclerosis and exercise. As I said, I've been working in exercise and multiple sclerosis for 15, 20 years now. It's hard to believe it's been that long. But this is the conflict that I and my colleagues are constantly running up against. The nature of MS encourages being sedentary. This makes exercise difficult. Being sedentary can worsen the effects of MS. Exercising too hard is going to lead to a pseudoexacerbation, a transient worsening of symptoms. Exercising too little is not going to lead to a meaningful improvement. Okay? So, how should people with MS exercise? What are we going to do? Is there an answer to this question? Let me give you a specific case example, and this is actually representative of probably 2 or 3 patients I see per week at this point, but it's a fairly common scenario. A new patient comes in to see me, and he says, I'm tripping when I walk. I'm tripping, I'm losing my balance. And I say, well, do you have an exercise program? And he says, of course, I exercise all the time. I know exercise is good for me. I do lots of upper body strengthening, and I lift weights, and I go to the gym, and I get in the pool and swim, and I do biking, and I'm in great shape. And said, well, how's the tripping going? He said, it happens every day. Okay? So I would have to say that the exercise program is not being of much help to you. He says, I know, I thought you said exercise helps. I'm exercising all the time. It's not doing anything for me. So I do an examination, and what do I find? I find the dreaded foot drop, okay? And most of you probably know what I mean by foot drop. It goes under many other names, but basically it's a catching of the toes on the ground. When someone's walking, it leads to tripping over the toes, particularly outside when there's uneven terrain, or the person develops some type of gait deviation to try to avoid tripping over the toes. And it results in a foot that looks sort of like this. As you can see, the toes are about 1.5 miles below the heel, okay? And it's due to a tightness of the calf muscles, the plantar flexors. Let's see if I can get this thing to work here. A tightness of these muscles here, the calf muscles, the plantar flexors, called the gastrocnemius and the soleus, and a corresponding and secondary weakness of these muscles here in the front, called the dorsiflexors. It's also often associated with spasticity, which is an abnormal neurologic-based tightness of these muscles, and also often associated with sensory loss. Okay, so what's the treatment? I'm certainly not going to give him any upper body strengthening treatment. I'm certainly not going to give him any aerobic treatment. He has that under control. He's not having treatment to address his specific needs. What did I do? It was a very simple situation. I give him a very prolonged and aggressive stretching program for his plantar flexors, and I know a few of you who I've been lucky enough to see here already know how big a point I make of stretching those muscles out. Strengthening of the muscles in the front of the foot, and on top of that, particular balance training to put him in situations where he may trip so he learns how to use that newfound strength and newfound range of motion. Okay? You've all heard the phrase, the right tool for the right job. Well, this is the right exercises for the right condition. Exercise is great. Everyone with MS should exercise, but if it's not the right exercise for your particular type of MS, it's not going to do you any good. Let me change that. It'll make you fitter. Okay, this guy was very fit. He looked great. He had a nice low heart rate. He had, nicely developed shoulders and biceps. He was extremely handsome, but he was still tripping. The right exercise for the right condition. Okay. Next thing I want to talk about is what I refer to as the volume problem. What I mean by volume is not telling my kids to use their inside voice instead of their outside voice. What I mean there is this. For change to occur, a sufficient volume of exercise must be performed. Okay? If you exercise too little, you're not going to get an effect of the exercise. Okay? If you think about, say, someone who's training for a marathon, if somebody to run a marathon must train to run 26 miles. If they only run 2 or 3 miles a day in practice, they're never going to get to that 26 miles. And I think that's a very good metaphor for what's happening in MS. To really make a meaningful improvement in MS, in any condition, you have to have enough volume. You have to exercise enough. However, in MS, neurogenic fatigue and thermosensitivity prevent this increased volume from occurring. So that's led me and my colleagues to ask the question, if greater amounts of exercise could be performed in MS, could we get better outcomes? Okay? We need to have more volume to get better outcomes. No one's been able to do the volume. If we could get more volume, would persons with MS improve more? So how can that be done? How can we perform a greater volume of exercise for our persons with MS? And to do this, we've been experimenting with what's called an intermittent exercise program, and we contrast that with a continuous exercise program. What do we mean by this? Most exercise programs are performed continuously without rest. When most persons with multiple sclerosis see a physical therapist, particularly a physical therapist who doesn't have specific training in multiple sclerosis, they will give them a typical exercise program and say, okay, first you're going to warm up with 10 minutes on the bike, and then we're going to do 5 minutes on the treadmill, and then you're going to do 10 minutes of exercise. And within 20-25 minutes, the person with MS, because of neurogenic fatigue and thermosensitivity, simply can't go on anymore. Okay? The body temperature rises, fatigue accrues, they simply can't continue. And the harder a person with MS tries to exercise, the worse the performance gets, and the less exercise occurs. And there's a film, I unfortunately don't have it today, of a patient of mine who is pure willpower. He's one of the most driven individuals I've ever met, and he wants to do straight leg raises, and he keeps raising his leg, and the first 2 or 3 he gets nice and high, and then the next 2 or 3 a little bit lower, and a little bit lower, and a little bit lower, and by the 8th or 9th he's screwing up every muscle in his face, he's gritting his teeth, he's grunting, and he can't raise his foot a 1/4 inch. Okay? That's continuous. What do I mean by intermittent? It simply means taking a rest along a certain point. Take rests over the course of exercise. I know this sounds almost too simple, but it's actually extremely effective. You take a rest to allow the heat buildup to diminish. It allows the fatigue to dissipate. It allows for greater volume of work. Now, some of you may be thinking, when should we take the fatigue? When should we take a break? It's going to differ from person to person. As I said, MS is a disease of tremendous variability. The one generalized rule I can give you is you probably need to take a break before you think you need to take a break. Take a break before you're tired. Don't exercise to the point that, okay, I'm so exhausted I can't move, time to take a break. No, take a break well before you're fatigued. Okay. So, at a study I'm doing with my students, my doctoral students at Hunter College now, we are looking at intermittent versus continuous walking. And can people hear me okay? Okay, good. Okay, and like much of the research that's going on in physical therapy, multiple sclerosis right now, it's quite simple because there simply hasn't been that much done. And this is accordingly a relatively simple study. We're taking persons with MS, we have them walk 6 minutes continuously, 6 minutes without a break. A week later, they come back and do the 6-minute walk again, but this time they'll walk for 2 minutes, sit and rest for 2 minutes, walk for 2 minutes, sit and rest, etc. Do that for 6 minutes. So the total time spent walking is the same, just one, there's some rests thrown in, the other there isn't. And we're simply measuring the distance walked, both total distance walked and distance walked every 2 minutes, and the amount of fatigue. So we've looked at 27 subjects so far, and we are not finished analyzing all the data, but when the subjects walked continuously, a total average of all subjects, 932 feet. When they walked intermittently, almost 200 feet more, 1,112 feet. And this was a pretty expected finding. Here's some from the first 4 subjects, just to give you a better idea. And I like this because it shows some fairly different initial values, indicating different levels of disability for each subject. Subject 1, continuously, 1,132, intermittent, 1,249, subject 2, 1,258 to 1,430, subject 3, 693 to 798, and subject 4 did obviously extremely well, went from 780 feet to 1,155. And we're just seeing this in patient after patient. The simple expedient of taking a few minutes of rest allowed a much greater volume of exercise to occur. So what does the research suggest? To improve walking distances, take breaks. The longer the total distance, and therefore a potentially greater volume of work occurs with walking intermittently. Intermittent walking, therefore, may offer a better stimulus to improve walking than continuous walking. And at the end of today's talk, I'm going to present a case for somebody who this worked extremely well. Okay, let's move away from talking about fatigue and walking and talk about something a little bit different, balance. I probably get the majority of referrals from physicians for patients who have balance difficulties due to the MS. Balance problems are an alarming issue for me. If somebody has a balance problem, that usually means that they're at risk of falling, and a fall for persons with MS could be potentially catastrophic. But balance is not a single thing. Balance is a combination of many, many, many different issues. It's multifactorial. There's no typical pattern of balance loss, and in MS, there's particularly no particular pattern of balance loss. There's multiple things that can contribute to it. However, I still find that fatigue is one of the more common findings for persons with MS who have regular, frequent falls. And this has led to the observation that falls appear to be much more likely in persons with MS when there's fatigue. So in another study that we're doing right now, we're simply doing balance testing in persons with MS, looking at them when they're fatigued versus a non-fatigue condition. Okay? So the subject with MS comes in, we give them a specific type of balance test called the Berg Balance Scale, which is thought to be a very valid and reliable indicator of falls risks in persons with MS. They take the test, and then I have them lie down for 6 minutes. At the end of 6 minutes, they stand back up and repeat the test. A week later, they come back in. I again give them the balance test. This time, instead of having them rest for 6 minutes, I have them walk for 6 minutes. And it doesn't have to be a fast walk. I just said walk at your typical comfortable pace, and then I repeat the balance test. What do you think we find? Okay, so apologize that my graphics are not as fancy as the previous presenter, but whoops, I didn't want to do that. Nope. There we go, the laser. Okay, so in this condition, you'll see the pre and post, the balance test before 6 minute lie down, balance test after 6 minute lie down, virtually no difference. In this condition, the balance test is repeated again, not that much of a difference. Then a 6 minute walk, bam, it falls down. Okay? And this was not a terribly surprising finding to me, but what was interesting when I shared this with my colleagues in physical therapy said this answers a question for me. A patient comes into my office, I give them the balance test, they seem to do extremely well in the balance test, yet they tell me that they fall all the time. Okay? So what does this suggest? Well, that fatigue is a very, very big variable in multiple sclerosis and exercise, and that good exercise performance in some cases and poor exercise performance in others may be explained by fatigue. As I've said many times already today, there's so much variability, and I think a lot of the variability, why sometimes persons with MS will say, early on in the day I feel great, then I get exhausted by middle of the day, then I seem to get some energy later in the day, then I fatigue much later on. I think the waxing and waning of fatigue that occurs over the course of a day in MS can really explain that to some degree. What does this mean for you as someone who's going to be exercising, someone who's going to be seeing a physical therapist? That an exercise program must take fatigue into account. An exercise program for somebody with multiple sclerosis must take fatigue into account. Okay, so I'd like to close with this case report. And this is a gentleman who I saw about a little over a year ago, I guess. It was December and January, or maybe a little bit earlier than that, of 2010, 2011. He was a 52-year-old man. He was diagnosed with multiple sclerosis 14 years ago. The EDSS, it's the Expanded Disability Status Scale score, which is a well-accepted, well-known measure of level of disability. Somebody with MS was at 4.5. And this is described as he was fully ambulatory without aid. Up and about much of the day, he was able to work a full day. He had some limitation of full activity, required some minimal assistance, but he was able to walk without aid, without rest for 300 meters. And this was pretty accurate for what he was describing to me. He said, I can't walk more than 4 blocks without tremendous fatigue. And then he said something which really stuck in my mind. Every year, my walking gets a little bit worse. I keep walking. I keep every day trying to go for a walk and push myself to walk as much as I can, as far as I can. And every year, it seems like I seem to lose a half a block, 3/4 of a block. And it's not for lack of trying. So on the evaluation, we gave him the 6-minute walk test. He did 1,050 feet, which is about equivalent to 4 blocks. He also had a foot drop. When I tested him on the balance test, when he was not fatigued, he had a very, very high score, suggesting a low falls risk. However, when I tested him after his 6-minute walk, his score dropped down quite a great deal, and he said very often after a long walk, he finds himself tripping and falling quite a bit. So I gave him a fairly straightforward program. I told him he needed to stretch the heck out of his left calf 5 to 6 times a day, 30 to 60 seconds a day. Oh, and by the way, I'm going to use this since I seem to be, how am I doing for time? Okay. Let me talk quickly about stretching, get off track for just a moment here. When I see somebody who has tightness in their calf muscle, and I could see that that's possibly a major reason for their falls, I say to them, oh, you really need to stretch those calf muscles out quite a bit more. And he said, oh, I stretch my calf muscles all the time like crazy, at least 20 to 30 seconds, 3 or 4 times a week, whether I need it or not. Okay? And what can I say? The dosage, it's too small. It's like he was taking 1/10 of the medication that he was needed to adequately control his MS. So for this gentleman, I said, you need to do it about 6 times a day for a minimum of 30 to 60 seconds every day, no days off. Okay? That this is an everyday thing for you from here on in. Okay? And then I gave him an intermittent walking program. He lived near a park, so it made it very easy. There were benches for him to sit down on. He would walk for 2 blocks, then sit down and rest for 2 minutes. Walk for 2 blocks, sit down and rest for 2 minutes. He did this for the first 4 days. He did it for a total of 6 blocks. Next couple days, 8 blocks. Next couple days, 12 blocks. He didn't like it. He said, Herb, originally I was walking 4 blocks. Now you're telling me to walk 2. But he stayed with it, thankfully. By the 12th day, we increased his walking length to 3 blocks, and I decreased the amount of recovery to 90 seconds. He kept this up through day 14 for 15 blocks, and through day 17, he was up to 18 blocks. At that point, we progressed to 4-block walks with about a 1-minute recovery. Okay. Kept this going for a while. By 45 days, he progressed to doing a 5-block walk 5 times over the course, and the recoveries were anywhere from 1 to 3 minutes. The first 5-minute walks, he needed relatively short recoveries. As the number of repetitions increased, he needed longer and longer recoveries. At this point, we also started testing to see how far he could walk without the considerable fatigue coming in, and he'd improved to 10 blocks. Remember that 45 days before, he had a maximum of 4 blocks. He was obviously quite happy about this. His 6-minute walk reflected this, 1,655 feet. His Berg Balance Scale score did not, when unfatigued, was the same at 55, but his fatigue was much less. He was able to get up to 52, and he said his number of falls, which we really weren't even treating that aggressively, had decreased, and his balance had improved. So let me summarize. I think Aaron's about to give me the hook. Okay. 3 main points I want to leave you with before I go away. Exercise will not lead to an exacerbation. When done correctly, it can actually mitigate the mobility deficits of your MS. Has to be done correctly. Second, you have to exercise specifically to meet the specific needs of your MS. No cookie-cutter approach, no cookbook approach, specific programs to meet your specific MS. And finally, to accomplish in a sufficient volume of exercise, you need to take breaks. Okay? By resting, you can actually get more done. Okay. Exercise program? Okay. Aaron's going to do some push-ups for us now. Okay. So after I've just finished telling everybody, no cookie-cutter approach for everybody, I have to find something for about 400 people here. It's kind of unnerving to see that guy there. He's not what I thought I looked like. As I said before, sedentariness is the problem. Too much sitting, too much time not moving, too much time bent forward. And you're all very graciously sitting here today listening to us, but you're all sitting. We need to change that. So I'm going to take you through 3 or 4 very basic exercises to try and counteract some of the potential harm that's been done by sitting stationary for too long. So first exercise, I'm going to keep this nice and simple. I'd like everybody to try and just pinch their shoulder blades together. Okay? Don't pinch it far back as you can. Excuse me here. Don't pinch far back as you can. Go about all the way back and then hold off by about 10 degrees. And just hold it there. Okay? Too much time we're spent bent forward with our arms crossed in front of us. Let's reverse that. Okay, while we're doing that, let's breathe in nice and deep. Try and fill your lungs up with air. Let the diaphragm descend all the way down. Okay, and keep that posture with the shoulder blades back. Okay, and now finally, let's relax back. Everybody, let's get your chins out of your chests and look at this nice lighting assembly they have up top. Let's extend our cervical spines. Okay, look up at the ceiling. Okay, now let's combine all 3 of these. Shoulder blades back, about 80 to 90% of the way. Tilt your head up. Okay, look at the ceiling. Take in a deep, deep breath. Fill your lungs up all the way. And now breathe it out slowly. Thank you. You may pay my receptionist on the way out.